Hello, I'm hematologist oncologist Dr. Tony Talebi. We're back with Dr. Brian Kim, Assistant Professor of Endocrinology at the University of Miami, and now we're going to discuss the actual treatment of papillary thyroid cancer. Okay, thank you for being here.
Pleasure.
All right, so let's assume a patient has had a mass in the neck, and that has been biopsied, fine needle aspiration, and it has come back positive for papillary or follicular cell. What happens next with that patient?
Okay, so I'll actually take one half step back because there's a clinical scenario that's very important that affects many, many people, is that when you have your biopsy of your nodule, the results can be benign, which is what we want. It can be inconclusive, which is not what we want, and we have to do further tests. Or it can be flat-out cancer, which means, and we're going to talk about that, but it's very common to have what's called a suspicious result. So if you have a suspicious result, or it's definitely cancer, all of those patients are recommended to have surgery. So thyroid should be removed. Now, for suspicious biopsy results, many of them, in fact, the majority, may not be cancer. So if you were a patient, for example, watching this video who had a suspicious biopsy, went to surgery, and they told you, surprise, it's not cancer. Well, that's not that big a surprise. And maybe if it's a very suspicious lesion, nodule, then it's only still a 50 or 60% chance of being cancer. So it's almost a coin toss, you may not have cancer. If it is definitely cancer, then it should end up as cancer on the surgery. But it's just being aware of that it doesn't mean that somebody made a mistake. If you had a suspicious nodule, went to cancer, and they didn't find cancer. This is actually very, very common, and this hopefully was explained to the patient before they went to surgery. But anyone who has a suspicious biopsy or a definite biopsy for cancer should go to thyroid surgery. And thyroid surgery means they remove the thyroid gland. Sometimes, if they're not sure, they'll start out by doing only half the thyroid gland. In other words, if they think that it's suspicious but they're not sure, they may take out half the thyroid, wait to see what it is, and then decide to take out the other half. But if you knew it was cancer, eventually all of it has to come out. So all of the normal thyroid tissue want to be removed. Now, depending on what the early results show, in other words, how big the nodule is on the ultrasound, what did the biopsy look like, what did the ultrasound look like for lymph nodes, the surgeon may do more than just the thyroid. They may also do what's called a neck dissection, and there's different varieties of that. They can do a central neck dissection, which means the lymph nodes in the middle, or they can do a lateral neck dissection on either side. But to some extent, the surgeon may or may not take out lymph nodes. And it's actually controversial among doctors in the field how aggressive the surgeon could start out. On the one hand, if they take out more lymph nodes, they're more likely to remove cancer that's hiding in the lymph nodes. On the other hand, if they remove more lymph nodes, they're also more likely to damage other structures in the neck and cause side effects. And again, we have to remember, in papillary thyroid cancer, the vast majority, 95+% of patients will never die from that cancer, even if it goes to lymph nodes. So we don't want to be overly aggressive at surgery. It's one of the mistakes of an immature surgeon, actually, to be too aggressive for a minor thyroid cancer.
Interesting. So when do you think is a good idea to remove the lymph nodes?
Yeah, so if you knew before surgery, based on an ultrasound, that there were suspicious lymph nodes, and I will biopsy those sometimes to prove it, well, in that case, they definitely should be removed, and their neighbors should be removed. So if you have a thyroid nodule over here that's biopsied and proven to be cancer, and then you have, or likely to be cancer, suspicious, but then there's also a lymph node over there that looks funny, we'll often do a biopsy of that. If that's proven to be cancerous as well, then the thyroid and all the local lymph nodes in that region should probably be removed at the first surgery. On the other hand, if the only thing that is seen is a thyroid nodule, then it's controversial whether the lymph nodes should be removed or not. And this is a subject of active debate among doctors.
How do you stage the patient, and what is staging in general?
Right, so staging is the process by which we try to figure out how much cancer was there. And what's implied in there is what you're really trying to do is say, what do we think is going to happen next? Like, the reason we stage is to say, well, you had this much cancer, and it was this big, and it was in these locations, and you're a patient of this age, of this gender. Well, now we give you a prognosis, and that might guide what we're going to do next. So the staging of thyroid cancer is actually kind of complicated in a way, in that at the beginning, when all you've had is your biopsy, maybe you've had an ultrasound and a biopsy, we can't really stage it. Sometimes we're not even sure if it's really a cancer. But many times after the surgery, we'll get additional information. It's very common for papillary thyroid cancer to show up in multiple spots in the thyroid at the same time. Strange but true. It can be multifocal, and it doesn't mean that it necessarily spread. You can actually present with 4 thyroid cancers in the same thyroid at the same time. Again, it's a little bit mysterious. But if we knew that, and we only know that after surgery usually, that changes how we think about your cancer, as opposed to if you only had one. Also, very important is if the cancer is leaving the thyroid, directly spreading to neighboring tissues, we call that direct extension, that's a bad feature of a thyroid cancer, so we want to know about that. We also want to know if lymph nodes are involved. We also want to know what the subtype of the thyroid cancer is. Is it papillary cancer? Mm-hmm. Within papillary, is it follicular variant, or is it tall cell variant, which is a more aggressive variant? But so after the surgery, we know a lot more about the cancer. But the staging is even more complicated, because in patients, and this is most patients with papillary thyroid cancer, not all, but most patients, they'll get radioactive iodine treatment after surgery. And the radioactive iodine treatment involves taking a pill of radioactive iodine that hopefully goes to where the cancer is. And if there's any normal thyroid left, it'll go there too. And that helps your doctor know how much cancer was there. Sometimes after the surgery, we think it's all gone. But after the radioactive iodine, we take a picture called a post-therapy scan, and we see more cancers in the neck or elsewhere in the body. So for me, in my clinic, the real staging is not done until the initial staging, until after the surgery and the radioactive iodine. So it takes a long time from the day that the nodule is felt to actually get to the first point of solid ground where the doctor can really start to talk to you about prognosis. I should mention that after the surgery, they can also start doing blood tests, only after the surgery. But after the surgery, they can do blood tests to measure a thyroid protein called thyroglobulin, which after your thyroid is removed should be very low in your blood. There's nothing to make thyroglobulin once the thyroid is gone. Mm-hmm. So if we measure that blood test after your surgery and the thyroglobulin level is very high, this suggests that there's trouble. It suggests that there's thyroid cancer hiding somewhere still in the body. Now, for the more academic-minded patient, there's commonly used staging systems that they use for almost every head and neck cancer that they're very poor how they work for thyroid cancer. So sometimes you'll hear your doctor talking about the TNM stage, which is based on the size of the tumor, how many lymph nodes are involved, and how many metastases, as well as the age. And suffice it to say that that's not something important for you as a patient to focus on, because when we do that for thyroid cancer, it ignores the biology of thyroid cancer, which most papillary thyroid cancers grow very, very slowly. Even if they're in the lymph nodes, they're not likely to spread out of the lymph nodes. So it can give you a very misleading prognosis if we use the TNM stage. So I use it in my patients for my record keeping, but I don't emphasize that when I talk to patients, because I think that you can get the very wrong idea.
So why can't you not do the iodine, the whole body iodine scan before the surgery?
That's a great question as well. So in your body, iodine is critically important to make thyroid hormone, and probably not a whole lot else. It's really to make thyroid hormone. And the tissues that love it are, number one, normal thyroid. So the normal thyroid gland loves iodine. It will suck all the iodine out of your blood. Your salivary glands like it a little bit, much less than the normal thyroid. And thyroid cancers, most of them, the ones that we say are well differentiated, for example, so this is not medullary thyroid cancer, but papillary and follicular thyroid cancers also like iodine, and that they like it less than the normal thyroid, but more than the salivary glands. So if we were to do an iodine scan before your surgery, all of the iodine will go to the normal thyroid. Even the cancer won't see it. If we could somehow remove the normal thyroid only, and then leaving the cancer, and then give radioactive iodine, now the cancer would see it. The trick with radioactive iodine, and we may discuss this later, is that the salivary glands, which are these big glands called the parotids in the back of behind your ears and your cheek, and in your jaw, the salivary glands that make your saliva, they make your spit. These guys like iodine a little too, and they can be damaged by the radioactive iodine. So that's a problem as well.
So tell me about the surgery. What are the possible complications?
Right.
How long does it take to recover?
So the critical thing about thyroid surgery is you need an experienced surgeon. And they always say that for all surgeries, but this is actually known in terms of research to be true for thyroid cancer. The more experienced your surgeon, the better their job they're going to do. This is just something that you get better the more you do of it. And that is in fact the #1 determinant that we can control in terms of how you're going to do as a patient. So by the time I meet the patient, or which is often after the surgery, probably the most important thing has already been done. It's not, what I do next is not going to be the decision-making point. It's that surgery is incredibly important. So it's worth it to ask your doctor who refers you to your surgeon and the surgeon to directly ask them, how many of these do you do? And if the answer is I do 4 or 5 a year, you would be better off going to someone else. And that you want someone who does dozens of these cases if you can find them. Unfortunately, not every patient has the access to search the country or for someone who's done 5,000 cases. But experience does matter, so I think the educated patient should know that. Now, the surgery itself is generally relatively quick. It can be the matter of just a couple of hours. Now, if unfortunately the cancer is more advanced at the time that it's diagnosed, the surgery can take a little bit longer. But remarkably, I've had patients, many patients, have their thyroid removed and feel like they could go back to work 2 days later. I don't recommend that because you're going through a stressful surgery and you get general anesthesia. But it can be a very, what you call, relatively minor surgery. People are generally eating, talking immediately after the surgery. There can be complications, which we're going to talk, I think we can talk about in just a second, but that most of the time the recovery is physically very, very quick from a total thyroidectomy.
So what are the specific complications that can happen?
So the specific complications involve 2 other structures in the neck. The first structures are the nerves, and you have one on each side, that control your vocal cords. So the vocal cords are 2 bands of tissue that are inside your windpipe that open and close, allowing different amounts of air to go through, and that's how you have a voice. So that's how you make sound. So the muscles that control those vocal cords have nerves that control the muscles, and those nerves go through your neck and sometimes right through your thyroid. Now, we cannot see those nerves on an ultrasound, nor can we see them very easily on a CT scan or anything else. So the surgeons have techniques to find those nerves as they are taking out your thyroid because they don't want to cut those nerves. But even the best surgeon, about maybe 1% of the time, will damage a nerve. And sometimes they didn't touch the nerve with their knife, but the blood supply that affected the thyroid may be also as important for the nerve, and it's interrupted when you cut the blood vessel, and there's just nothing that the surgeon can do. Wow. So that, unfortunately, vocal cord paralysis is a risk. Now, if you have, many patients have a mild version of that, and they have a weak voice for a few weeks or months, but then the body can adjust. The muscles can grow bigger, the innervation to the other parts of the muscles take over, and your voice comes back to normal. If not, if you lose one side, then you're going to have a weak voice, but that can be surgically fixed. They can close one vocal cord so that only the other vocal cord does all the moving. Now, if in a very severe case, if you were to lose vocal cords on both sides, this unfortunately would be quite devastating, and that would be you wouldn't be able to speak. You would have to have what's called a tracheostomy tube to speak. This is exceedingly rare, and unless the cancer is involving both sides of the neck, you will almost never see that. So I think it's fair to tell a patient that they should not be worried about that happening. I've actually never seen that in a patient who didn't have cancer just everywhere. So for the vast majority of patients, that kind of losing your voice totally is not in the cards. Now, the second complication relates to the parathyroid glands. Parathyroid means next to thyroid. And you have 4 or sometimes 5 of these little glands. They're like little lima bean or little pea-shaped glands that are also actually very hard to see on ultrasound. So it's hard to find them if they're normal. and they're all around your thyroid. Sometimes they can even be inside your thyroid, and sometimes they can share a blood supply with your thyroid. So the surgeons all know that they've got to find these glands and try to save at least one of them, because you need one to have normal parathyroid hormone levels. And parathyroid hormone is very, very important from your calcium. Since we're on the subject, the parathyroid hormone sort of has an opposite effect to what calcitonin does. And calcitonin, if you remember, is the hormone from the parafollicular or C cells, which become medullary thyroid cancer. Anyway, if you were to lose your parathyroid glands, then your blood calcium levels can drop, and that's a big problem. Your calcium is supposed to be kept in a fairly narrow range in your blood, and if it goes low, you can get cramping and tingling in your fingers, tingling in your lips. If it goes really low, you can have muscle spasms and heart rhythm problems. So that's something we look for after surgery. It's very common to have a little dip in your calcium after thyroid surgery, but the vast majority of patients, it's a temporary situation. The doctors will give you extra calcium pills and a powerful kind of vitamin D, and extra normal vitamin D for maybe a week or two after your surgery.
I see. So let's say that the entire thyroid gland is taken out, then does the patient need treatment with the Synthroid?
So then, because the thyroid gland is removed, your body has no way to make thyroid hormone, and your body needs a certain amount of thyroid hormone all the time. So absolutely, you need to take thyroid hormone. How it's replaced is actually somewhat controversial in that the vast majority of doctors give you the major circulating form of thyroid hormone, which is called levothyroxine. And Synthroid is just one brand name, but there are others, so for example, Levoxyl. There are other brand names, Unithroid. There are actually many other brand names, and depending on what country you live in. But levothyroxine is the real name. And your body actually converts levothyroxine to the active form of thyroid hormone, which is called liothyronine. Levothyroxine is sometimes called T4, and liothyronine is called T3, because T4 has 4 iodines, T3 has 3. My lab studies this, so this is something dear to my heart, I guess you could say. Anyway, for the vast majority of patients, if you just take T4, levothyroxine, that's fine. That'll give you a normal amount of thyroid hormone. Some people possibly need to take the active form as well, the T3. This is a major area of controversy, and I'm actually on the panel for the American Thyroid Association that's reviewing our guidelines for this. But you need some kind of thyroid hormone, and for the vast majority of people, levothyroxine is enough.
So you need that right immediately after surgery,
You
correct?
do. If you forgot it, if somebody forgot to write the prescription for you, you'd be okay for a couple of months, and that you would not die, but you might become hypothyroid. You'd have the symptoms of low thyroid. You'd be cold, tired, depressed, dry skin, constipated. You'd have a tendency to gain a little bit of weight, and so you wouldn't feel great. So that would be a mistake. You would definitely want to be put, basically there's no reason to wait. Well, let me just check that. Unless someone is planning to do your radioactive iodine immediately right after surgery, in most cases you probably should just be started on thyroid hormone.
So let's talk about this radioactive iodine. Just explain to me, how does it work? When is it administered after surgery?
Sure. So most patients have a very treatable, if not curable, thyroid cancer. And for many of those patients, just the surgery alone can cure the cancer. The problem is, we don't have a test or a battery of tests that 100% prove that you're cured. So after surgery, your doctor has a good idea of how much cancer was in there. But it's not perfect, because they don't know 100% for sure if all the cancer is out. They can do a blood test to measure this thyroid protein called thyroid globulin, which can be very informative, but even that blood test doesn't tell the whole story. They can do an ultrasound to see if anything was left, but that's not 100% informative. So that the doctor has to decide, should I do more treatment just based on what they already know? What came out at the surgery? How old was the patient? How big was the tumor in the beginning? And so in most cases, if you have anything but a very small, innocent-looking thyroid cancer, most doctors recommend another treatment called radioactive iodine. So radioactive iodine, the principle is that thyroid cells and thyroid cancers like iodine more than the rest of your body. So if we can give you radioactive iodine, the only parts of your body that are going to eat it and hold on to it are the thyroid cells, if there are any left, and the thyroid cancer, hopefully. And in that way, we can kill the thyroid cancer. So for really, I guess, gosh, more than 40 years now, this has been a part of the treatment of thyroid cancer, that after surgery, for most patients, you'll get an amount of radioactive iodine designed to kill anything that the surgeon couldn't get. Now, the preparation is a little bit complicated. I'll say a couple of words on that. So, generally speaking, we want to prepare your body for this radioactive iodine. And one way that can be done in some centers is by putting you on a low iodine diet. So this low iodine diet gets rid of the non-radioactive iodine out of your body. And that way, when you take radioactive iodine, it's not fighting against the non-radioactive iodine. So that's one way to be prepared.
And what is the diet?
The diet is a very, very restrictive and complex diet, which unfortunately can be quite difficult. Now, there are free entire cookbooks available online of how to cook the low iodine diet, but the number one problem is salt. And that because the United States used to be an iodine deficient country in the entire northern United States for almost like a century practically, maybe a little less than that, getting towards a century now, we've been putting iodine in the salt, and that has really helped fix that problem to a large extent. But that means if you go to a restaurant in the United States, there's a very good chance that all the food you have is going to be filled with iodine. So you pretty much can't eat out. And that there's also chemicals that are used in commercially prepared foods, like most breads from commercial bakeries, that they have certain preservatives with iodine chemicals in them. So iodine-containing chemicals. So basically, you have to really restrict what you eat to a list of things that are on this low iodine diet.
How long do you need to be on this diet for?
It's actually very controversial. So almost everything in radioactive iodine is controversial, unfortunately. It makes my job much harder as a doctor because I have to tell my patients, well, if you go to 3 top-notch hospitals in the United States and ask that question, how much should I be on the the low iodine diet? Some places will say, oh, you have to be on it for 9 days. And that's it. And for example, they may not check what your iodine levels are. They'll just say do that diet. Here at the University of Miami, we're on the extreme, that we put you on the diet until we can measure from your urine that there's not much non-radioactive iodine in your diet. Other places that are on the other extreme might say, well, we are not worried about this, and we're just going to treat you without putting you on the diet. And this is not absolutely proven by research to be important. And the key point is this. We all know that if you had a lot of non-radioactive iodine in your blood, the treatment won't work. So for example, if you have a CAT scan with contrast dye, and contrast dye is filled with iodine, if you try to do radioactive iodine treatment right after that, it will absolutely not work. But the question is, does it work better if you start with a normal level of iodine that you would have from your diet, which is much lower than you would have with a CAT scan? Or is it better to lower it further? And we believe here at the University of Miami, and as do others, that it's better to lower it so that the radioactive iodine can go directly where it needs to go, and it's not competing against non-radioactive iodine.
Okay, so let's say the patient is on the low iodine diet, then what happens next?
Okay, so they're on that low iodine diet. They also have to be prepared in another way, and that is, we want any cancer cells left in the body, and if there's any little bits of normal thyroid left, we want that to be prepared as well. Let me just do another aside and say, why would there be any bits of normal thyroid? Does that mean the surgeon is bad? It does not mean that. The thyroid gland during development drifts down with the heart. The heart keeps going into the chest, but sometimes the thyroid gland ends up in more than one piece. Also, the thyroid gland can actually be stuck into the muscles, and little bits can break off. So you can have little bits of thyroid in the muscle that we sometimes call parasitic thyroid. So the surgeon can't get that stuff out. So you could have the world's best surgeon, and there could be little bits of thyroid still left. So when I talk about that, it's not because somebody made a mistake. But anyway, you've been on the low iodine diet. We want your body, we want those normal thyroid cells and any cancer to be hungry for iodine. And the way to do that is by raising the level of another hormone called thyroid stimulating hormone, or TSH. And TSH is a hormone that you will learn about as a thyroid cancer patient. It is the hormone from the pituitary gland in the brain. It's right between your eyes and the middle of your head. It comes down and tells the thyroid gland to work harder. Now, in this setting, there's no more thyroid gland. But we can either give you this TSH hormone in the form of shots called recombinant TSH or thyrogen. Or we can stop your thyroid hormone for a few weeks and your body will naturally make TSH. Either way, the TSH levels go very high, and that thyroid stimulating hormone stimulates the residual tissue to take up that iodine. So in the short term, we want that TSH to be very high for the iodine to go into the cancer cells, and the cancer cells can then be killed. Now later on, it's the opposite. We want the TSH to be low because we don't want thyroid stimulation to be happening. But in the short-term preparation, it's low iodine diet, then it's either stopping thyroid hormone or injecting thyroid stimulating hormone. Either way, that makes the TSH go very high, and then we give you the pill of radioactive iodine.
So generally speaking, how long does this all take? 2 weeks, 3 weeks?
Yeah, generally it depends on the diet. And so some patients naturally have a low salt diet, and when we check their urinary iodine, they're ready to go from the beginning. Other patients have trouble. Now, so if they are struggling with the diet, it could take a few more weeks. It could take 6 weeks. On average, I think it's fair to say that most patients receive radioactive iodine 2 or 3 months after their surgery. I, for example, in my practice, don't believe in rushing directly from surgery to radioactive iodine. First of all, there's no data saying it's better. Second of all, the side effects of the surgery, recovering from the anesthesia, the stress of all of that, then we're going to overlap with the diet and the stress of going through the radiation treatment, which I think you can start to have side effects piling up on each other. I see no advantage to it. So 2 to 3 months is typical after the surgery. I treat many patients 4 months, 5 months, 6 months out. We actually don't know if there's an optimum time point. Like, is it good for the neck to heal after surgery so the blood supply is good so that the radioactive iodine can go to the cancer? Well, then maybe we should wait. On the other hand, should we strike while the iron is hot and try to kill the cancer as soon as the surgery happens? Oh, then maybe we shouldn't wait. So we don't actually know. So what happens is typically 2 to 3 months. I tell my patients there's no good time to do it. So I never delay things for no reason. But for example, in my own practice, if somebody has a big family reunion or a wedding and they want to delay their treatment by a week or two, as far as I know, that makes no difference whatsoever. So by all means, we should just do that.
Okay, so let's talk about the treatment itself. What happens? Please explain the treatment.
Sure. So the treatment itself of radioactive iodine is not too complicated. Basically, if you're at the University of Miami, you've been on this diet, and we've checked your urine to make sure your urine iodine levels are low, so there's not too much iodine in your body. You've either been off your thyroid hormone or you've gotten these shots. Then you come to the hospital, we hand you a pill, and you swallow it. That's it. Now, depending on what state you live in, what happens next varies. Here in Florida, at least our institution has interpreted the Florida guidelines from the state to say that we should keep everybody in the hospital. In a state where, for example, I trained in Massachusetts, you don't have to do that. So here in Florida, you're going to stay in the hospital, just sitting there. You're not doing anything. There's no further treatments. You just swallow the pill. But you sit there and get bored, hopefully, for a couple of days until your levels of radiation drop so that they feel that it's safe for you to go and be with other people. In a state like a state like Massachusetts or New York, on the other hand, they'll hand you the pill, they'll tell you to go straight home, and they'll tell you to stay home for the next 3 or 4 days. So it varies, but the whole treatment is just swallowing the pill. Because the pill is radioactive, you are radioactive once you swallow the pill. The radioactivity hopefully is going to go to those cancer cells and stay there for a few hours or a few days. Really, the longer it stays there, the better. But all of the radiation is going to rapidly leave your body in your urine, in your saliva, and your other secretions. So that each day after you swallow the pill, the amount of radiation in your body is dropping by probably more than half. So by a couple of days later, the amount of radiation in your body is very, very low. And this is one of the reasons why in other states than Florida, the state government has decided it's okay for people to just go home.
Can family members be around the patient?
Right. So, for example, in Florida, here at the University of Miami, we do not allow patients to have their families around during this first 2 days after they swallow the pill. The theory is that even though the amount of radiation coming out of the patient is very low, no one should have unnecessary radiation exposure. So even I, as a doctor, do a very minimal exam. I basically talk to the patient in the room unless they get sick. The nursing staff spends very little time in that room. On the other hand, if I had a patient who, we hope this would never happen, let's say they had another medical problem, and they just happened to have a medical problem unrelated to thyroid cancer while they're radioactive, it would be totally fine for me to treat that patient. I would just run in there and do whatever I have to do. The net effect of standing next to somebody or sitting next to somebody for an hour, let's say the first day of they get the radiation, yeah, maybe you get a CAT scan too. But one CAT scan is probably not going to kill anybody.
Right.
At the same time, we don't want anyone to get a CAT scan who doesn't need it, because any radiation should be avoided. So in other states, what we recommend, like when I practice in Massachusetts, we tell the patient to go home, to sleep in a bed by themselves, and act like you have the flu. Just imagine they have a horrible flu, you're sneezing, you're coughing, you have a runny nose, no one wants to be around you. You would never go to the movies and put your arm around your spouse and then say, yeah, let's watch Gone with the Wind for 4 hours while I'm coughing all over you. Same principles. If you just pretend like you have the flu, if you were in the same room, across a big dinner table or, across the kitchen from someone, they're going to get a minimum exposure. But we basically just, use common sense and you'd be fine. Again, depending on where you live, we don't actually let you leave the hospital here in the University of Miami until your levels are so low that you couldn't hurt anyone if you tried.
Now, how do you know if the treatment's worked?
Yeah, this is actually not trivial. To know if it was a good idea that you got radioactive iodine or not can take a long time in some cases. So the first major landmark is we do this scan after the radioactive iodine called a post-therapy scan. And that you've swallowed the pill, and about a week or 10 days later, they take a picture. And what this picture is where the radiation is that's coming out of your body. Now at this point, this is a tiny amount of radiation. So, 10 days later, you couldn't hurt anyone else if you tried. Although you could set off a detector in an airport, so we have to give patients a letter so they know not to travel if they've just had radioactive iodine. Otherwise, in the early days, people got arrested for this because they thought they were terrorists. So, unfortunate. Anyway, this post-therapy scan is going to show, is there anything in the body, particularly in the neck, that really held on to that iodine very well. And luckily, most thyroid cancers will. So the thyroid cancer will light up. Now, because again, even with the world's best surgeon, you can have little bits of normal thyroid still in your neck. That can light up too. So we actually can't necessarily tell if what we're seeing on the scan is normal tissue or cancer. Also, after surgery, everything moves around. So just even based on the location, we can't tell. But the bottom line is if I see something that lit up, then that's either normal thyroid or cancer. Either way, we want it gone. So then I can say to that patient, oh, see, look, this is why we gave you the radioactive iodine, because that stuff was left after surgery, and we want it gone, and this will hopefully get rid of it. But to answer the question of whether the cancer, if there is any, is killed by the radioactive iodine can take more than a year. Because it turns out that while the radiation comes and goes over the course of a week, the effect of the radiation can be much, much more prolonged. So that you can have a big response early, but we can see improvement in the blood tests and other tests we do more than a year after radioactive iodine. So even though the radioactive iodine was given 11 months ago, I can say to the patient, oh look, your blood tests are getting better and better even now. It's not because there's any radiation that's left. It's because the cells were exposed to the radiation. Their DNA was damaged, and then they are going to start to die off.
So I guess next comes a TSH suppression therapy.
Yeah, let me actually I'll definitely talk about that. I think I forgot to talk about the complications of the radioactive iodine, which are very significant in how we think about this, so I don't want to forget. So the radioactive iodine, because I mentioned that the normal thyroid loves it best, the cancer is number 2, hopefully, but the salivary glands are number 3. And that if we give a dose of radioactive iodine, there's a chance that we will destroy the salivary tissue and also the tear ducts, which also like iodine. And so the problem with radioactive iodine is, especially as we get to higher doses, we can cause the salivary glands to die. So for most patients, this just means a slightly drier mouth. But the worst case scenario, which now we're talking much less than 10% of patients, worst case scenario, you can lose your salivary glands completely. As they die, they can cause pain and swelling. They can blow up when it's time to eat because you're salivating because they're blocked. Then they unblocked and you get a funny taste in your mouth. Then that happens again, and that can go on for months. So that's a very serious side effect. You can, if the tear ducts are blocked, you can have excessive tearing in your eyes. That actually can be surgically corrected, but the salivary glands cannot.
How often does that happen?
So mild versions are common, maybe 20-30% depending on your dose. But that severe case I just described, we're talking about, you know, maybe 1 or 2% of patients, even with higher doses. So it's not common, but the patients have to know about that. And that can kick in at any point in the first year to a year and a quarter after treatment. So unfortunately, some patients will be doing great when they leave the hospital, and 2 or 3 months later doing great. Then all of a sudden they'll wake up someday and their cheek is swollen, and it's a little painful. Again, mercifully, that's not common at all. Unless you have a very, very large dose of radioactive iodine. And the dosing of radioactive iodine is incredibly controversial. Most doctors give a bigger dose if they think the cancer is more aggressive, and a smaller dose if it's less aggressive. So then you would ask, so what else do we do? Then we do something called...
Let me just ask you one other question. What if your patients ask if they want to have children? Do you recommend...
Great question. Okay, great question. So it turns out that the radioactive iodine can have a short-term impact on fertility, but it seems to be only short-term, so we do not routinely recommend sperm banking or egg harvesting. It seems to be not needed, but we also recommend that patients do not get pregnant for at least the 4 months after the radioactive iodine is given. There are unfortunate cases, this should never happen, but it's happened, where a patient has gotten pregnant right after radioactive iodine or something like that, and that can mean that the baby will be born without a thyroid. But it turns out that as long as the mother is taking her medication, the pregnancy can still go okay. And the baby can be okay, albeit likely to have to take thyroid hormone. If it turns out, even worse mistake, from my point of view, if we were to give a big dose of radioactive iodine to a pregnant woman without realizing it, if it were after the baby's thyroid is made in the first 12 weeks, the baby would probably be okay, actually.
Great.
Probably, but you never know. So we would never want to test that theory. But luckily, it seems that fertility long-term is okay. Now, with a woman, because of the subject we're about to discuss next, we do make their thyroid hormone levels high in order to suppress another hormone called TSH, and this could, unfortunately, impact fertility. So this is something we have to talk about. So why don't we talk about TSH suppression? So the only other thing that's called a treatment, aside from the surgery and the radioactive iodine, that is routinely done in all patients is to give a big dose of thyroid hormone to lower this hormone from the brain called thyroid stimulating hormone. And the reason is that in the long term, we don't want to have thyroid stimulation because it might stimulate the cancer. It turns out that probably most cancers don't care, and it's probably only a small subset of patients for whom this even matters, but we can't tell who it is without doing the experiment of saying, what would happen if your TSH was high? And that's not an experiment we want to do. So right now, we tend to make everybody hyperthyroid, lower the TSH to a low level, and we do that until we feel confident that they're probably disease-free, meaning for about 5 years.
Well, how do you know if they're hyperthyroid?
So we do a blood test for TSH, so that the TSH is in fact the goal. The point is not to make the patient hyperthyroid per se. The point is to lower the TSH, because we don't want thyroid stimulating hormone to stimulate everything. So the easy way to do that is to give an overdose of thyroid hormone, and the brain senses that, and the brain shuts off TSH. Now, someday you can imagine if someone invents a drug that lowers TSH without causing hyperthyroidism, we would probably all prescribe it. Because the hyperthyroidism is not the goal, it is the unfortunate mechanism by which we lower that TSH.
I mean, do you want the TSH to be 0 or just...
Not quite 0. We want it to be low, and there's a number people use that's less than 0.1, but you have to be careful because there's more than one TSH assay, and they have different normal ranges. But we want it to be close to 0, but not actually 0. What happens is the TSH blood test is very great blood test. It's very sensitive, and your brain is very sensitive in how it makes TSH. It's sensitive to changes in your thyroid hormone levels. Well, if I give you a big dose, your TSH will go way down. It'll get close to 0. If I double or triple your dose now, it doesn't have too much further to go.
Right.
So we could end up with a huge, massive overdose if the TSH is all the way 0. So we like the TSH to be just measurable, and that way we know that, okay, we don't have a ridiculously high overdose happening, but on the other hand, the TSH is as low as possible, avoiding that situation.
I see. So then what happens next? How do you check thyroglobulin?
Right. So now you've had your biopsy, you've had your surgery, you've had your radioactive iodine. The doctor has now sat down with you and we've talked about, okay, this is how much cancer you had, and based on all of the tests that have been done, this is where it was, and this is what we think the prognosis is. But now we enter what's called surveillance. So we have to say, we don't have a test or even a combination of tests that 100% proves that you're cured. So we now are going to do a series of tests over time to look for the cancer. And those include this thyroglobulin blood test. And thyroglobulin, again, is this protein. It's actually the backbone on which thyroid hormone is made. And so it's stored in these big pools in the normal thyroid. Luckily, most thyroid cancers, and we're talking about the follicular-derived ones, papillary and follicular thyroid cancer, those cancers also try to make thyroid hormone. They fail, but they succeed in making thyroglobulin. So it's an excellent tumor marker. So in other words, if you've had your thyroid removed and you've had radioactive iodine to get rid of the rest, and a year later I'm able to measure a lot of thyroglobulin in your blood, this is bad, because where's it coming from? It's going to be coming from cancer. So we do that blood test about every 6 months. And interestingly, there's 2 ways of doing it. The usual way is we just measure it, and because we're giving you this overdose of thyroid hormone, your TSH is low.
Yeah.
It turns out that the TSH is very important for the thyroglobulin, so that if your TSH were higher for any reason, whether we inject TSH into you or your brain makes more TSH, any cell that can make thyroglobulin, including thyroid cancers, will tend to make more thyroglobulin. So once in a while, your doctor will ask you to do what's called a stimulated thyroglobulin. So they'll want your TSH level to be very high instead of very low, just for a short period of time. Because again, the high TSH is not considered to be a good thing. But they do it for just a short period of time. Then they measure your thyroglobulin to see, it answers the question, how high could that thyroglobulin go if there was a lot of TSH stimulating the body? And that can give some important prognostic information as well.
So what if the thyroglobulin does begin to rise? What do you do?
Right. So if the thyroglobulin begins to rise, we want to start to do other tests. And the other tests can include an ultrasound of the neck, because the vast majority of recurrences of thyroid cancer, more than 90%, are all going to be in the neck, in these lymph nodes. That's where thyroid cancer likes to go, and that's where it tends to live. And luckily, that's usually the extent of where it likes to go. It doesn't generally like to spread to the lungs or bones, although it can do that. But an ultrasound is actually part of the standard routine once a year for sure anyway. But then, especially if that thyroglobulin level is rising, we're going to want to start doing additional tests to figure out where is that coming from. So we'll do an ultrasound. If the ultrasound doesn't show us, we might do what's called an iodine scan. And this is just like the radioactive iodine treatment in that we prepare you in similar ways, but then we use a very, very low or weak dose of radioactive iodine. It's not going to hurt you, it's not going to damage your salivary glands any further, but it's just used to find whatever tissue can concentrate iodine. Because at this point, with the normal thyroid gone, with the cancer gone, the only tissues that should still concentrate iodine are salivary glands here and here. So if we see something in the bottom of your neck that can light up with iodine, meaning it concentrates iodine, that's either normal thyroid or thyroid cancer. Those are the only 2 things that are going to do that. So that scan can be useful to find that. If that fails,
Let me just ask, let's say, what if you do find something on the thyroid scan?
So depending on how we find it and where it is, we're going to do something different. So if we find that there's still thyroid cancer, say a year after your radioactive iodine, well, at that point, you've probably had all the benefit of radioactive iodine that you're going to get. Let's make it a year and a half to make it easier conversation. So it's been a year and a half since your radioactive iodine, we find some thyroid cancer in the neck. We really don't think the radioactive iodine that you had a year and a half ago is now going to make this go away. So we're going to treat it. And the number 1 way to treat thyroid cancer always is surgery. So if we have the option of doing surgery, we always want to do surgery. And that the surgeon will go in, take out whatever thyroid cancer is found and all the lymph nodes in the area, and that neck dissection hopefully will get rid of and cure the cancer. And we will do the same tests after the surgery.